Well, hello everyone. My name is Dave Stern and I will be your guide through VelociDoc here today. I've been with Practice Velocity since we started back in 2002, and it's been fun to work with all of you. Our distinct pleasure and joy to work with so many wonderful clients all over the country and watch you succeed in serving your communities, serving the patients that you work with, and making a difference in your communities. Practice Velocity is the owner and maker of VelociDoc, the EMR, and we're delighted to say that 16.2 release of VelociDoc, we believe, is the most significant change in charting that we've seen for urgent care so far. The VelociDoc EMR has won every award ever given for urgent care EMRs, and we think this really takes it to the next level. Now, let me just describe what we're going to be doing here. For the next hour and 40 minutes, we're going to be going through the entire VelociDoc system. This will be a training for somebody as though they've never, ever used the system before. So if you've used the system, you're comfortable with it, and you don't really feel there's much for you to learn, then feel free to step off and come back at what will be actually 3:45 Eastern, 2:45 Central, and 12:45 Pacific. If you feel you're comfortable with the system, you can just come back in an hour and 45 minutes. Otherwise, I'm going to be taking the rest of you through a journey through VelociDoc as though you've never used the system before. As far as questions go, feel free to go ahead and open up the sidebar that's in the GoToWebinar solution, and you can go ahead and type in your questions in the chat section, and we'll be delighted to answer those questions, but those will all be done at the end. Unfortunately, it's very hard for me to keep track of questions as I'm going through here. So with that being said, we'll go ahead and get started. Again, this is a once through the whole system. We will be coming back in an hour and 40 minutes, and we'll be going through just the new updates to the system, the chartlet updates, and a couple other little updates that are coming out in a couple weeks. So if you're comfortable with the system, feel free to go ahead and sign off and come back in a little while. Okay, so we're going to go ahead and get started here. Let me go ahead and make sure you can see my screen. And you should be able to see my screen now. We were getting a couple questions from folks that say they're having trouble seeing the screen. Just give me 1 second here, make sure you can see the screen before we get started. Okay, false alarm, it looks like. If you're still having trouble seeing the screen, go ahead and log back into the meeting. If you're still having trouble, message us again and let us know. If you're really having trouble, call 815-713-2687, 815-713-2687. Let them know you're having trouble seeing the screen, and we'll get a support person to help you with that. So, that being said, we're going to go ahead and get started. The way the VelociDoc system works is you have the ability to see all of the patients in the clinic and all of the, whether they're in the waiting room or on the top panel here, the room patients on one screen. Any patients that you've discharged previously will show up in the bottom panel. So you have these three panels, and this speedy chartlet here I'm going to remove from room here, and you can see speedy chartlet is down here in the waiting room right now. I've been in the waiting room in the clinic at least for 76 minutes. That's probably a little long, maybe coming out of the room soon and asking, did anybody forget about me? So you'll see the patient there, and this is what we call the tracking board. You can see here I'm at a clinic called Belvedere, and I can see I am on today's date, 5/12/2016. If I want to go backward a day, I just click on the arrow to go backward a day. If I want to change the day, I can change the day here to the 3rd or back to the 12th. Very simply, all it's just left clicks. If I want to open the practice management solution, I can click up here in the top and click on PVM, Practice Velocity Management. And when I do that, this screen will open up here, and this will allow me to see the patients that are in the clinic from the front desk view. Can also run reports here if I have access to reports in PVM. And in addition, I can go in and put notes on a patient. So Speedy Chartlet could have notes put on that patient. We already put a note in on this patient earlier, a clinical note, and we could put another clinical note in if we wanted. I'll do that right now. I put in that the patient was a VIP, but we'll put in that the patient is not to get additional narcotics. That's actually meaning the same thing in many clinics, but we'll go ahead and put that in there. And I chose that as a clinical note, and we'll add that. So if I want to add clinical notes, you do that in PVM, and that allows you from visit after visit after visit to see the same note on the patient. Shortly I'll show you where the clinical notes show up. Now, if I want to take a Speedy Chartlet and move Speedy Chartlet up into room 7, I right-click on Speedy Chartlet's name and left-click on the room, and Speedy Chartlet ends up in this room right here, exam room 7. I can see that Speedy Chartlet's a 27-year-old female, and it's a private patient. The types of patients you'll see are private, work comp, and employer-paid services. Employer-paid services are drug screens and physicals that are billed to the company directly on a once-a-month basis. And then you also have the work comp, which are injuries that occur in the workplace. And then private patients are everything else. Private patients do include Medicare, they include primary care patients, and they include, for most of you, mostly urgent care patients. So now that I've got the patient here, Speedy Chartlet, in a room, I can go ahead and open the chart. Now the way the VelociDoc system works is that the first open of a chart, as I did just here, actually finishes compiling the VelociDoc system on the local computer. VelociDoc is actually a Windows application, and so I have just finished compiling that here on my system. If the patient's birthday is coming up any time in the next 14 days or occurred in any time in the last 7 days, I'm sorry, in the upcoming, if it's in the upcoming 14 days or happened in the past 7 days, your staff will be reminded to tell the patient happy birthday. Encourage your staff not to take credit for it and just say, no, it's no problem to remember it. It said so right here in the system. That's actually a mistake because then patients don't give you any credit for remembering their birthday. But if they notice everybody's remembering their birthday, they'll tend to think that's really cool. And every time somebody opens this chart, they will see that it's these birthday notices coming up. So now the chart itself on this patient this is a new patient, so there's no data that's been filled out. But I can tell some things about this patient by looking at the chart. First of all, I can see this green RX. The green RX tells me that the patient actually has already had these pharmacies selected, and I can see here that the pharmacy it's selected is the bogus pharmacy, so to speak. So that green means that. If your clinic is set up such that it will show up yellow, a yellow RX button up there means that there is a pharmacy listed on this patient, but it has not been confirmed by your staff on this visit. Most clinics actually have it set up for the front desk to always confirm it, and so you will essentially always see it as green. In addition, you see here this little note icon has a blue dot on it, and that blue dot means that there's a clinical message. If there's an alert, mainly a billing alert, it would be a red dot, and there's a couple other dots that might show there, different colors, but the one that you're really looking for is the blue dot. That's a clinical note, and as I registered the patient, I said the patient was a VIP, and then we also put in this note here by opening up PVM and putting it on a note on the patient in PVM not to get additional narcotics. That will carry on for visit after visit after visit, although it can be inactivated within PVM. So for single visit notes, as we saw back here on the tracking board, These can be entered by the front desk on registration, or if you want to change the single visit note here, you just click on it, and you can put it on sore throat, or let's put in sore throat times 3 days. So you can have your front desk put in the complaint here on the tracking board, or your staff can put in the complaint as a note here in the tracking board, simply by clicking on the field and then retyping or typing in the information there. Now, to get back to the chart, I click on Window, and now I can see I have 2 windows open. I could have multiple charts open at the same time, but I've got this Speedy Chartlet and I've got the tracking board, and I'm going to switch back to the Speedy Chartlet. Now, if you notice you're getting a message saying that your computer is running out of memory, there is a limitation on the 32-bit Windows setup, and that 32-bit Windows setup gives you a somewhat limited memory in the system. It's a limitation of Windows. It's not a VelociDoc limitation. So if you see that message popping up, the first thing you want to do is see if you can close a chart or 2. Shortly, you'll be able to move to using the 64-bit functionality in Windows, and when you're able to do that, that will probably be a future release. But when you're able to do that, you should no longer see those messages, because you'll have essentially unlimited RAM available to you in the VelociDoc system at that point. Okay, so if you see the warning, though, that you're running out of memory, just close a chart. And a chart or 2. You may have too many open. Sometimes people have a tendency to keep 5, 6, or even 10 charts open, and that's too many for the amount of RAM that Windows allows a Windows app to utilize. Let's go ahead and maximize that. Okay, so we've got the patient here. We've got all these red tabs across here: Chief Complaint, HPI, Review of Systems, Past Family Social History, Exam tab, Assessment and Plan tab, and Code Summary tab. They're all red, meaning that they're really expecting documentation on every one of those. If it's a typical patient visit, there would be. If the patient's just coming in for a flu shot, it is fine to just document in the Vaccine tab, leave all the other tabs red, and go ahead and discharge the patient. But typically, for the average visit, you will actually document each of these red fields and have them change to a different color, and we'll do that as we go through here. Let's start out by putting in the vitals. We'll put in the temperature of the patient. We'll say the patient has a little fever of 102, and this clinic has defaulted to Fahrenheit. It could be defaulted to Celsius if that was your choice, but it's one default for the whole practice. It's up to you to choose your default. Let's actually make the pulse normal, and up here you'll notice the vitals are filling into the window, this salmon-colored window up top. The temperature is 102. The pulse is 96. 96 is within normal range, but the patient obviously has a fever. The pulse, blood pressure, and respirations are normed for the patient's age. So if you have a pulse of 110 in a 6-month-old, that will show as normal. But if you have a pulse of 110 in an adult, that will show as abnormal or red. So you can look at those numbers and be comfortable that if they're black, they're in the normal range for that patient's age. If they're in the red, they're not. So let's put in a blood pressure here, and we'll put in a normal blood pressure. I can type, or I can choose, which I did just there, or I can choose to click on this little calculator type input window. Respirations will say is 16, and again, I'm clicking on it, but if I want to type, say the O2 sat is 96, I can type and put that in just the same. When I put in oxygen saturation, it will ask about the delivery of oxygen, and I'll say, in this case, room air. If the patient is, if you get the height and weight on a patient, what you want to do if you're doing meaningful use, you can put that in there. If you are set up by the Joint Commission for accreditation, then you want to do a pain assessment on every patient, which you can say not completed due to an emergency condition or a non-communicative patient, but typically you would fill it out here. Even if the chief complaint was pain, you fill it out here as well as in the chief complaint, but typically you would just fill it out on every patient. So, this is warning me that the BMI is out of range. I can go ahead and close that out because I'm not going to do anything with that. And I can see here the vitals are are all in now a green window instead of that salmon-colored window. The reason is I have a complete set of vitals on this patient, so it's turned green. The temperature, as you can see, is out of range, and so the patient has a fever, and that is showing in red as out of range. Now, we've got this top panel completely covered. There is a save button over here on the right that would be used when I'm done with the chart for now, but not ready to discharge the patient, and I would save the chart. But you can leave charts open as long as you're not seeing Windows warn you that you're running out of memory. You can leave it open. One last thing I did skip over is the historian. This will be set for a child. For someone older than, I believe, 7 years old, it'll be set as self, and you can always change it to father, mother, or whatever you want to put in there. If you want to put in other, and when you put that in there, you type in who the person was, aunt, grandma, whatever. But I'm going to put in self and leave it at self, because an adult, it'll always say self unless you change it. Now, let's say the patient has a chief complaint of a sore throat. I click on the location of the complaint. I can be more specific. In this case, there's no need to be more specific. And then I can pick sore throat. Now, you notice sore throat has this little chartlet icon next to it. None of the other complaints do, but in the neck, the sore throat has that chartlet icon. Other places that you'll see the chartlet icon are, for example, if I click here chest, I'm going to see cough. If I pick GU, I am going to see painful urination. So I can go through here and see different chartlet complaints, and we'll talk about what a chartlet complaint means here shortly. Let's go ahead and click and say the patient has a sore throat. Now, before I click on that, notice where my arrow is. I am not trying to hit that little dot to the left of the word sore throat. I'm just on the word. And in most places in the chart, as long as you click on the word next to the box or button will automatically populate. In this case, the patient's chief complaint is a sore throat, and it's recommending that maybe I should do a strep screen. And that would be a recommended procedure in most urgent cares to do if the patient has a sore throat. Now, I'm going to go through the chartlet functionality here, and then we'll go through the regular functionality in a little bit. But let's start out with the chartlet functionality. You see here, when I clicked on sore throat, I suddenly got this information over here to the right called, this tab over here to the right, chartlet. And we'll take a look at the chartlet in a minute. The first thing I need to do is, though, put in the history. I'm doing the work that the MA should be doing right now, or the nurse, depending on how you staff. So I'm going to go over here to the review of systems, and I'm going to ask the patient, any change in appetite, chills, or fatigue? No. Any fever, sweats, or weight loss? Well, yeah, I've had a fever. What's your highest temperature been? I don't know. I just felt feverish. Okay, then I click there and save that out. And now I've got that information documented. Any chest pain, fainting, flooding, or palpitations? No. Any headache, lightheadedness, loss of consciousness? No. Any numbness, tingling, poor balance, weakness? No. And I would recommend your MAs go through and ask these questions of all true urgent care patients. If you have a patient that's a true recheck for a problem, if they were in a couple weeks ago or even 10 days ago for a laceration, then we typically recommend that you only ask the questions that are in yellow. These ones that are in yellow are actually considered to be related in some way to the chief complaint. And so they would ask these questions related to the chief complaint rather than all of the questions in the review of systems. But that's the differentiation there. True follow-ups, we recommend that they ask just the yellow highlighted questions. And for all other patients, if they're truly urgent care patients and not well known to the provider, then focusing on a full review of systems allows you to catch things you might otherwise miss. Now, going back here to the chief complaint, the yellow tab here, you can see it's yellow. That means I have it. I have some elements completed. I haven't completed the HPI, and I won't complete the HPI if I'm an MA or nurse because that's not my job. CMS has said that the job of doing the history of present illness is the provider's job. But what I could do is I could type in here sore throat times 3 days. And I can go right down here and ask these questions and fill them out. It's exactly how the patient, how would you describe that pain? Well, I'm not sure. Is it sharp or scratchy or dull? Oh, it's sharp. And we already got the 3 days in here about when it started. Is it constant or coming and going? Oh, it's constant. Okay, constant. And rating on a scale of 0 to 10, 0 being no pain, 10 being the worst pain you can imagine, where would you rate this? And they might say, oh, the pain is approximately a 8 over 10. And were you exposed to anybody with a sore throat? And they say no exposure to anyone with similar illness. Okay, so that's documented here. That is in a triage note, and that can be filled out by the nurse. If you're using the kiosk with the patient putting in their own history, the patient would have filled this information out here when they filled out their history of present illness. But this is not adequate. Just accepting this is not adequate. It needs to be documented by the provider in order for you to get credit for your history of present illness. Now let's move forward here. We saw we did the review of systems, and that's completed, and that's turned green because I really have completed that to the highest level. I'm not an MA or nurse, so I'm actually registered in the system as a provider, and so this is saying that the provider has edited this whole document here, the review of systems window. If I was an MA or nurse, that would not be checked. Past family social history, in this case, is also empty. The first thing I notice is the bogus pharmacy has been selected, and I know based on this green icon here that that has been confirmed on today's visit. So I really don't have to ask the patient again. If I say no meds, no allergies, no medical problems, no surgeries, no street or unprescribed drugs and so on, no tobacco, no alcohol or street or unprescribed drugs, I've got all that in there, and I can say no medical problems as far as the family history goes. Now, to document items in here, for example, on medications, I can click on Add and pick Zocor. Come down here to Z, click Zocor. The 500 most commonly prescribed meds in the U.S. formulary are sitting right there, so most of the time you'll be able to find the med right there. If they know all of this information about quantity, dose, and route, that's great. Otherwise, I could have just added Zocor here by clicking here rather than adding the real dose. It's best to add the dose whenever possible. If you have a medicine that you find is not on the list here, you can go here to medication search, and under medication search, type in medication. And you can see as soon as I type in a few letters, it searches for me, and I can pick, in this case, amiodarone. So we've got the Zocor in there. We've got the preferred pharmacy above that. The allergies, it can be added. Whenever I try to add an allergy, and I've already said no allergies, it will not allow me to have those two together. So let's go ahead and add now, and we'll say patient has an allergy to penicillin. The 20 or so most common allergies based on actual documentation of patients' visits in our system show right here on the left. So I can pick penicillin, and we'll say a severe allergy with rash, swelling of lips, and shortness of breath, and save. Now, you notice peanuts aren't on there. I can type in peanuts, and I can pick from all these different items here as well. The patient has a peanut allergy, which is a severe allergy, and we'll say it's also an anaphylactic type reaction. If the patient is allergic to, let's say, lettuce, you can add an unlisted allergy by typing over here, because it didn't show up when I did the search. And now I can put it in here like this. And now, in that case, it's not a true allergy. I'm going to say it's a moderate intolerance with some abdominal pain or cramping, and save that out and close. So we put in the allergies there, and you can see lettuce, peanut, and penicillins are my allergies here. And now on the medical problems, the patient's on Zocor, so odds are the patient has high cholesterol. I can click here on high cholesterol, dyslipidemia. You see I've got a lot of choices here. I could say pure hypercholesterolemia, and pick that and pick it over here, and that makes it show up down here with both an ICD-9 and an ICD-10 code. All problems in the system are documented that way, both ICD-9 and ICD-10. Now, what I want to do here to pick the date diagnosed is go here to the calendar, and let's say the patient was diagnosed in January of 2014. So I click here, I pick January, then I click here again, I click on the year again, and I pick 2014, January, and now I'm going to pick January 1. If you don't know the date in the month in which the patient was actually diagnosed, you pick the first. It's a little buggy, I know, but it's actually what the federal government for meaningful use requires us to put in there. It also is showing that I modified it or put it in here on today. The status is currently active. But let's say the patient's pure hyperglyceridemia is better at some point, I wouldn't change it. But if it becomes completely resolved, which would be very unlikely, but if it did, I would put in resolved, or I could put in this case chronic, because it really is a chronic problem. I can also type in here that it is improved with Zocor. This is a note that I can modify with each visit to note these items about a person's medical problems. Surgeries can also be input, and let's say the patient actually had an appendectomy. You click there under abdominal pelvic surgery, and then you can document further if you choose to with the pop-up that comes up. We're just going to skip that at this point, and we'll go forward here. Now, at this point, I've done the review of systems, I've done the past family social history, and I've put in here the chief complaint is a sore throat. You notice the chief complaint HPI tab is yellow. It should always be yellow when the provider first goes in or when the nurse or MA is first done, because remember, it's provider work to fill out the bottom of the HPI. So I'm going to save this out as the MA or nurse, and I'm going to save it to a provider. Now, if I want to pick a specific provider, I can do so, and then that provider will show up on the tracking board and we'll know that that's for that provider. So let's go ahead and save that, and now the chart closes down, and Speedy Chartlet now I can see is a 27-year-old female with a sore throat and a fever, and that was noted here that the patient had a sore throat for 3 days by the front desk. So all of that information is in there, and I can now go ahead as a provider, open the chart. So I'm going to go ahead and open my chart, and give it a second to do so. It's downloading the entire chart onto a local encrypted database on my tablet or PC. Why is it doing that? Well, it's downloading that because that's the architecture of the system. It's designed to work so that if you lose the internet intermittently here or there for a second or two or a minute or two, you may not even notice it happened because you're going to be working on your local PC most of the time. Exceptions would definitely do occur at times when you do a search for a diagnosis sometimes, or when you do e-prescribing, you will be using the internet. But typically within the chart, you're staying on your local PC and you're not spending time communicating across the local database. Now, the review of systems would not show provider reviewed, and the past family social history would not show provider reviewed if this had been filled out by an MA or nurse. In this case, I filled it out and I'm in the system as a provider, so they all showed as provider reviewed. So you can see all the tabs are red except the HPI, which is yellow. And I'm going to say, so I understand you've had a sore throat for 3 days. Yes. And it's been going, it's constant, and you rate it as an 8/10. Yes. And you said you didn't have any exposure to anyone with similar symptoms. And they say, yep, that's correct. If they said I did have exposure to somebody with strep throat last week on Wednesday, you could put that in, and you could even say whether it's at homework or somewhere else, and save that out. So now you notice I have a complete HPI, and it's in green. Now I notice there's a chartlet here. That's because the chief complaint has this chartlet icon, and there's a chartlet associated with sore throat. Chartlet is what we believe is the fastest way to chart a patient's visit compliantly. Now there are ways of just saying populate a physical exam for a sore throat and the treatment and everything else for a sore throat with one click. That one-click charting is not compliant according to CMS, but if I go in here to the chartlet, you'll see here I can see a lot of information here. I can see the whole history, present illness, review assistance, past family social history, and I can click here after I reviewed it with the patient, and in one click, it closes that window out. I can open it back up simply by clicking here. I can close it out by doing here. So this little arrow over here on the right allows me to open or close the history. But I'm all here right on this one tab, and now I can go down through here and I can say the entire ENT respiratory system is negative. And I do that with a single click here by saying all normal. Now all these yellow highlighted items in the ENT respiratory have turned green. And I can uncheck if I didn't check hearing, and I didn't maybe do another thing, I can check that. And if something is abnormal, let's say the pharynx and tonsils are abnormal, and I want to note in here that the tonsils are symmetrical with no exudate, but they are red and swollen moderately. I can put that in with just a few clicks. So I've got the exam documented for the ENT. You notice the exam tab is being populated with this information over here. The exam tab is turning yellow. Let's go to the exam tab. You'll see it's similar here. If I go to the ENT respiratory, I can see here down in the body area that there's a lot of these have been documented, but these were documented over in the chartlet functionality. I can also draw on a diagram over here, but I can't do that from the chartlet itself. I have to go to the physical exam tab to do that. Doing this with a regular mouse, if you're working on a tablet, you can do it with the tablet as well. I do have tablet functionality, so if I want to go ahead and draw in there, I can. But sometimes with the finger, it's a little hard to get it very accurate. Anyways, you can see those are maybe almost more than moderately swollen. Let's go back to the chartlet here and just finish off our charting where I can do this much faster. I say well-developed, well-nourished, normal mood and affect, no neck mass, no evidence of monohepatitis, no cervical lymphadenopathy, no scarlet fever, no rash. Breath sounds are normal. You notice the exam tab just went from a light green, or from a yellow actually in this case, to a, let's do that again, to a dark green, meaning I now have 8 systems documented, and we'll go here to say there's no splenomegaly and hot auscultation is normal. Splenomegaly in this case would be potentially associated with mono. We're going to go ahead now and order a rapid strep test. When I did order that test, you see a red box shows up to the left of the strep test. And the labs tab turns red. Why? Because I've ordered a test, but it's not yet complete. Back here on the tracking board, I hit refresh, and I can see here the strep test is there on the tracking board. It's in red. The strep test is in red, indicating that it's been ordered but not yet done. Now, the MA or nurse can just simply click on this red strep test icon here, or not icon, but box. And when they do that, they'll open up the labs tab. And when they get that labs tab, they can say, oh, the strep test was collected, and it was positive, and save that out. And now you see that whole row has turned yellow, and they'll save that out. And each section, labs, procedures, x-rays, can be opened separate from the rest of the chart. And the reason for that is because I told you we're working on a local PCs. I'm working there all the time, but if I want to, let's go back here to the tracking board. If I want to refresh that, it still shows that the strep test is red, even though the results are in there. But once I save it out to the server, this information that it's ready for the provider, which I can see in my version of the chart, but I can't see from the tracking board because the tracking board refreshes from the servers. When I hit Save Section, you notice the Labs tab now is yellow, still yellow, but out here on the tracking board, I've saved that section, and now the strep test is yellow. Yellow indicates that it's been completed and it's ready for provider review. Red, it's been ordered but not yet, the results are not yet in yet. And green means it's completely reviewed. Well, the provider then is in the chartlet, never leaves the chartlet, can see here that the strep test is positive and can simply click on that strep test as the reviewed, and it turns green. So I don't have to go anywhere to review it. I just click there and say, yep, I'll review that. Now, if you do not have provider privileges, you will not be able to review a test here. So if you see a yellow positive and you're a nurse or an MA in the system and you click on that yellow box, it will not turn green unless you have provider privileges. Now, if you are a provider and you click on that box and it doesn't work, that means you're not set up in the system as a provider and you need to talk to your administrator about your setup. If I want to order an X-ray, I can do the same thing. Order the X-ray by clicking on it. In this case, I wouldn't be clicking whether it's right or left. You notice it's grayed out. Why? Because it's not appropriate to do a right or left chest X-ray. The two-view chest X-ray is bilateral by definition. And technical component means I'm only going to be billing for doing the actual performing of taking the film. Professional component only, which would be very rare, I'm only going to be billing for reading the film. Both are generally incorrect. For the most part, most of our clients, you'll be billing both aspects. But if you're not, you can pick one or the other. Now, I've ordered the chest X-ray. Now, it does warn me after that order that this patient might be pregnant. The last menses were not recorded. So that was a mistake, but we're warned about that when the X-ray tech went in to do an X-ray. It also warned the X-ray tech. But simply putting in the last menses as being recent and saving it will go ahead and get rid of that. Now, I can also put in calculate EDC if I want. That would be kind of silly since that doesn't actually make sense. So let's just delete that. But if last menses was more than 28 days ago, then I click calculate EDC. I would see that there. Okay, so we've got the chest X-ray ordered, and out here on the tracking board, when we refresh that, here is the chest X-ray showing up in red. Red means, again, ordered but not yet done. The X-ray tech goes into the X-ray tab, and in the X-ray tab, the X-ray tech can set note, for example, the abdomen and pelvis were protected and the neck was protected. The patient walked to the room. These are mainly for Joint Commission, but anyone has this and can document the transportation and shielding issues. And then they click ready for reading. When your staff click ready for reading, then out here on the tracking board, you'll see, or when I refresh it, that it's yellow. Remember, red meant it was ordered but not yet done. Yellow means it's done. It's ready for the provider to read, and the provider can then go in here and read the film. Now, those of you who are using this, we are integrated now, fully integrated with teleradiology specialists, a teleradiology company. They're the largest teleradiology company in urgent care, doing a great job for lots of urgent cares all over the country. Most of the major chains use teleradiology specialists, and we are integrated so that the results can come right back into the system. If you haven't been set up for that integration or you don't use teleradiology specialists, feel free to pick up the phone and talk to our team about that. But if you are set up, it's important to go ahead and read the film anyways, because if you're billing for the reading of the film, it's not the radiologist at teleradiology specialist or some other radiology company that is going to bill this read. In most cases, the reading is going to be billed under the provider's name who actually saw the patient in the clinic. And so you're the credentialed provider with the payer. You're the one that the billing is going to go out under. It is important that you read the film as well and use the radiologist read as a confirmatory read. So even if you see a read from the radiologist, go ahead and read the film yourself. In this case, I'm going to say there's a diffuse right middle lobe infiltrate, and save that out. I clicked all normal to get all of these green, and then I went ahead and typed in the specifics. If I want to edit it, I can just click there on that spot where the words were and edit again, say, whoops, that was the right upper lobe, and save that out, and now I have right upper lobe there. Save. Okay, so we have that in there, and now I can go ahead and save that section out. Again, that saves to the server. Now you can see I've completed all the required areas here on this chart, and they've all turned dark green. The exam tab, remember, was based on the level of exam. When I had 8 systems, I went to the highest level of exam. Over here in the Progress Log tab, if I want to add a second set of vitals, I can do so. I can also see the alerts, and this exclamation mark told me there was an alert here on this patient. I should say a note on this patient, and it's showing as an alert here in the system, which is just the chief complaint in this case. If I want to do a second or third set of vitals, I can do so here by clicking on Vitals and putting in the patient has a temperature now of 100 degrees instead of 102 as it was when the patient came in. And I can also do a post procedure pain assessment, although most templates where it's appropriate actually already have the pain assessment within the template, and you can fill it out within the template itself. I put in here the patient has a temperature of 100 degrees, and when I look here at the medical record, which is very easy to look at here in VelociDoc, over here by clicking on the transcription tab, and then I come down across here, I can see all the abnormal things that we've documented have show up here in red. The reviewer systems that are abnormal actually are pulled out of the entire reviewer systems that is negative. So these are all the negatives. The positives are at the top here. Then when I look at the allergies, by definition, they're all going to be showing up in red. The meds in red, medical history in red, and then down here under the vitals, you can see the patient has a fever. And then under the physical exam, I've got the tonsils have no exudate, but they're red and moderately swollen, symmetrically. All the rest of the physical exam that I documented was completely normal, so it showed down here in black. Here's the strep test here, and you can see the results were positive. X-ray results here, you can see that there's a diffuse right upper lobe infiltrate in this case, and you can see here in the progress log, here was the temperature redocumented. So we've got a pretty fully documented chart here. I put in a progress note. If I wanted to just type in a note here and say anything appropriate about the patient, I could do so. If you're using the system for the first time and you just cannot figure out how to document something, if you're in a rush, just type it in here. If you're not in a rush, call support and see if they can help you with that. Now, they're not all clinicians, so they may not be able to immediately figure out how to do that, although in most cases they can answer it. But if they can't answer it, they can certainly get to a clinician here at Practice Velocity and get the question answered. In the interim, feel free to go ahead and document in progress note what you weren't able to find in the system. You always have the progress note available to you, and you can put in as many progress notes as you want. It's not a substitute for using the templates, but until you learn where certain templates are, it makes sense to use a progress note just so that you get your chart compliantly documented. And you can see my nonsensical note is now there. If I want to edit that note, I can do so here. And save out again. And now the more nonsense shows up there. Now here in the assessment and plan, because the patient had a sore throat, there are 5 common diagnoses that we found that providers pick. These are the 5 most common in order. And then down below that are the 20 or so, whatever shows on my current resolution of the screen down here alphabetically. It does include the top 5 as well. And if I want to see about 50 related diagnoses that are statistically, not etiologically, but statistically related to that complaint, I click there and I can see it. So sore throat is actually statistically related to headache and hypertension. Why? Because these are in the top 50 diagnoses on patients that have a sore throat. They're probably on the top 50 on virtually every single complaint as well. But you can see most of these are related to a URI in some way, sinusitis, bronchitis, bronchospasm, conjunctivitis even. Sinusitis, I already said, stomatitis, they're all there. So those are the top 5, the top 15 or 20, whatever shows here, and then to list all of them, click at the bottom and you can see the whole window. So that's one way to get your diagnosis. I'm going to do it here though from the chartlet because I would have been staying on the chartlet the whole time. And I'm just going to say strep pharyngitis. Now, when I go here and say strep pharyngitis, just one click, strep pharyngitis, boom, and now that diagnosis has been selected. Okay, let's see if it's there. I didn't click it. There we go. And they'll say no workup planned, prescription drug management, and I'm going to give an exit care for strep throat, easy to read. Now, this is the one place where you do absolutely have to check the box and not the words next to the box here in the system. They're on this exit care instructions. So let's go back up here and talk about the diagnosis or episode. There are 3 types of diagnosis or episodes via the Marshfield Clinic Guidelines and the CMS algorithm for coding for complexity of medical decision making. A lot of words you can just ignore there, but if you're a coder, you got what I said there. So new condition, established condition, or minor. So if the patient comes in with a new condition, you would pick a new condition, or if the patient comes in with an established condition, unless it's a minor condition. Minor condition will overrule the other 2. So CMS has defined a minor or self-limited issue as something, basically said, an insect bite or ringworm. So if the patient comes in and says, I think I have an insect bite, and you look at it and say, yep, you have an insect bite, you take some over-the-counter cortisone cream and let us know if it gets any worse. They really didn't need to come to see their doctor. They didn't need any prescription drug management. They simply came in for a diagnosis and reassurance. If the patient comes in for a diagnosis and reassurance and really doesn't need any prescription medications at all, then that would be considered a minor problem. But patients come in, most patients who come in with something a little more significant than a minor problem. And if it is a little more significant than a minor problem, you should check new or established condition. Now, just a warning to you, one of the most common coding errors made with our system and resulting in significantly higher codes than should have happened on a few patients, not a lot, but a few patients here or there, is a provider picking new condition or established condition when it really is a minor condition. So remember, self-limited problem, didn't need to see the provider, just needed some reassurance and some OTC meds at the most. That is a minor problem. But the rest, pick new or established. Under new or established, you have choices here. So if I say workup planned, it's going to give me a differential diagnosis, and I could type in mono versus strep versus viral and then save that out. It's important to put in a differential diagnosis if you're doing a workup. In this case, I did the workup in the clinic. There's no workup plan beyond the clinic, so I would pick new condition, no workup planned. If the patient comes in with strep throat and they were seen a year ago for strep throat, this is a new episode, and we actually have the wording here, diagnosis or episode. This is a new diagnosis or episode. Therefore, it would be a new condition, no workup plan, because there's no workup beyond this visit. Now, if I ordered a strep culture, then it would be a new condition workup plan, and I'm doing a workup for to figure out exactly what type of pharyngitis the patient has. If I'm doing if this patient came in with a UTI and I was sending out a culture on that UTI, it would be a new condition workup plan. If as a patient came in with back strain with radiculopathy and I was concerned about a herniated disc, I would go ahead and click here, new condition, workup plan, and then I would say a back strain versus herniated disc versus tumor or whatever else I want to put in my differential, and leave it at that. Remember, the patient will see your differential, so be careful to, if you're handing the patient their discharge instructions, they'll see the differential as part of the diagnosis. So make sure any differential that you're putting on the chart you're actually discussing with the patient. So that's the new conditions, workup plan, no workup plan. Most commonly, in urgent care, new condition, workup plan is no workup plan. New condition, no workup plan is appropriate for approximately 80+% of the patients seen in urgent care. Often more than 90% are coming in with just a new condition, an acute condition. They want treatment. It's not self-limited, minor. It's not going to resolve on its own, or if it did resolve on its own, still resolve significantly faster if you give some prescription medication. Then established conditions are worsening or stable. And every diagnosis must get defined as new, established, or minor. And then if it's new, workup plan or no workup plan. If it's established, worsening or stable or improving. Many of the conditions you see are stable, improving. That's appropriate. If it's gotten worse, you pick worse. And all the work for complexity of medical decision-making coding happens behind the scenes. All you need to do as a provider is do everything that's appropriate, document everything you did, and in almost all cases, the system will code appropriately. That's fairly straightforward there. So we're going to say this is a new condition, no workup plan, new strep throat, no workup plan. Then we'll go down here to the risk. In this case, you're just selecting the highest level for the visit. It's not necessarily the highest level for this diagnosis. Doesn't necessarily mean that you're doing prescription drug management for this diagnosis. It means for some reason you're doing prescription drug management on this visit. Prescription drug management could involve giving an IM shot of Rocephin, an IM steroid, while the patient's in the clinic. It could involve giving a prescription to the patient for antibiotics or some other medication, managing their hypertension medications. Any of that would qualify as prescription drug management. And then down here under exit care, you can pick from the ones that are listed here, or I'll show you, you can also search under the exit care under the extra care tab, which we're not on here. Now, I said recheck in 3 days if not better. I could have scheduled a recheck, so I told the patient to follow up with the personal physician or any of these other items down here. These are radio buttons, so this is just what are they to do next. If you're going to do some additional discharge instructions, you would pick from the bottom section here, including additional discharge notes, work status, physical education notes, school notes, consults, another provider, for example, further studies orders or therapy orders. So this is just the next thing they're supposed to do is follow up with a personal physician in 3 days, or recheck in 3 days if not better. It'll also say sooner if worse in the text that's generated from this recheck in 3 days. Let's go here to the additional discharge notes. I can pick from a list that I've created right down here, and I'm going to say call for fever over 102. Maybe I want to edit that. I can edit it right here and say over 103 since the temp's already 102. I'm going to put in the work status note here, and in the work status note I can say off work and may return to work on Monday, the 16th without restrictions, and save that out. If the patient wants a school note, I can say back to school in 3 days and save that. And if I want to order other studies or consult or therapy orders, I can do that. If this is a workers' comp and I want to create a provider-to-provider note, I can click there and add one if I want to. I click that by mistake, so I can delete that. And I'm going to click here and say consider MRI at next visit. This is not part of the actual medical record. The provider-to-provider note is a note that you're leaving in the visit history for the next provider or for yourself to even remind you that you can want to maybe do this MRI on next visit. This is typically used for work comp, especially when you know you're going to be on vacation and not available, but you don't want to put this necessarily into the medical record. You can leave this note for the next provider to see the patient. So let's go ahead and put that in there. And now you can see we've got this full chart filled out. I can see here the code summary has changed colors, so now I even have a full E&M code. In this case, we have a level 5 history, level 5 physical, and a complexity of medical decision making of a level 4. All my codes that I've generated so far have been put down here, 99204. I have my ICD-10J02.0 for strep pharyngitis. There's ICD-9 and SNOMED codes. Most of us are now ignoring those codes, but they're there for completeness and also for meaningful use criteria. We also have an X-ray code here. The chest X-ray, 2-view chest X-ray was a 71020, and the lab, the strep test, had a 87880 code. So we've got a fully coded chart, a fully documented chart, and we were able to do all of that really, although I was going back and forth between tabs, we would have been able to do all of that right here from the Chartlet tab. And that means the only thing that I haven't done is do my prescribing. So I can launch my prescription window here, and that does pull up another screen if I'm doing prescribing. Looks like it's just going to ask me to do go forward here, so I'm going to go forward. Now, This is the screen you come to typically when you open the ePrescribe. And when you open this up, you have 3 options for prescribing, or actually 4. I can re-prescribe a med from here. If the medication has been prescribed, has been noted on the past family social history, but has not been prescribed in the system, then the SIG doesn't show here, and I can click on here and create the SIG. I click on the med, the hyperlink, and create the SIG. Or I can go ahead and type in up here under drug search and add a medication. So if I want to give the patient amiodarone, again, kind of an unusual med, to give in the urgent care setting, especially for a sore throat, but let's just say I did that, I can click here on amiodarone and go forward. With some patients, it will give you instructions about and whether it's covered on the patient's insurance. However, this particular chart, because it's not a real patient, doesn't show that. There are some cautions here you can see on amiodarone to warn the patient about grapefruit may increase serum drug concentrations. We're going to go ahead and click here on amiodarone, and we're going to create a prescription, 1 tablet by mouth, TID, for 10 days, or for 30 days, we'll say. And you notice when I click on 30 days, it automatically populates because it's TID, 1 tab. It's going to put, the prescription is going to be for 90, number 90 in the bottle. Now, I can go down here, and I can see how the medication comes. In this case, it comes in blister packs, 100, number 100 blister pack, or a bottle with 30. So this information is just informational. You can't click on it. It's not functional. I can talk about refills if I want to, but typically in the urgent care setting, we leave most things at 0 there. If you want to say PRN or dispense as written and don't use a generic, you can do that here. You can say that this is a one-time prescription instead of putting in refills. And you can also say, you know what, I want that amiodarone, 100 milligrams, TID, to show up regularly for me, because I'm going to be prescribing that a lot for patients. And so I'm going to save this SIG. And so I'm going to save this SIG and add it to my doctor's list. And I can say, watch or do not eat grapefruit, or grapefruit juice I could add as well, but we'll just leave it at grapefruit. And I'm going to save this now at this point with this button right here, save. The system is set up on the ePrescribe for most of the buttons you're going to click a lot to be in red. So you can see I've got this red button here, which would be to go forward with this prescription. But I've got the amiodarone prescribed 3 times a day. Do not eat grapefruit. And I can also now go down to the doctor's list. Here's my doctor's list. Every provider has their own doctor's list. So it's a little confusing. It should really say prescriber's list or provider's list, but it says doctor's list. But every nurse practitioner, every PA, every MD has their own unique doctor's list. And I'm going to click on that and open it up. Now, when I open that up, you can see here the amiodarone, 100 milligrams, 1 tab by mouth, TID, number 90, don't eat grapefruit. All of that is now here on my doctor's list. So with a single click, I could prescribe that. And I'll actually prescribe it again, and there you see it just showed up twice on this patient. Now I'm going to not prescribe that. What I'm going to go here is back to my doctor's list. And let's say there's 2 meds I want to prescribe on this list. I want to do amiodarone and amox. Click, click, and say select. Now it's warning me about the allergy the patient has to penicillin, but nice enough, with just 3 clicks, I was able to then prescribe both medications on this patient. Now I still can go forward the amoxicillin, I can delete the amiodarone, that's fine. Now every clinic can also be set up with drug sets or compounds. This is generally set up by the medical director, and we do recommend that the medical director set these up so that you have some PEDS dosing here available to you of common meds for PEDS. So PEDS 10 to 20 kilograms. Here's a list: Biaxin, Amox, Zithromax, Ibuprofen, Bactrim, and Augmentin. I don't need to do any math. I simply click on the med and prescribe it. And bingo, I've got that ibuprofen prescribed, and I know I have the right dose for a 10 to 20 kilogram kit. What if I want to do, so that's how you do your pediatric doses. It needs to be set up by your medical director. It populates everybody in the clinic once that's done. Secondly, though, let's say for sinusitis, I like to prescribe Amox and Mucinex, or let's say, back to the drug sets, let's say for back pain, I like to prescribe indomethacin and Flexeril. I can just prescribe both meds with one click, and they're now prescribed, Flexeril and indomethacin. I've got the ibuprofen on there as well, which I can delete if I want. So I've got all of those things prescribed with a single click. Just open the drug sets compounds, pick the back pain item in this case, and then say prescribe all, and I get both at the same time. Let's close that out now, and let's talk about how to set up a drug set or compound. Remember, to set up a medication on the doctor's list, you simply prescribe a medicine, and when you're prescribing the medicine, say add to doctor's list. Check that box and it will be added. If I want to delete it from the doctor's list, I simply go back here, click here in the right-hand column and click on remove from list. And now when I go back here, and you can see the amiodarone is gone. So I can add it simply, I can delete it simply from my list. Now, we've got those two items done. Let's talk about editing your drug sets. Your drug sets can be edited. Once I've opened my drug set, let's go. Let me close the doctor's list here. Here's my drug set. Build drug set compound list. So one of the things that's nice to do is when you're building a list is to make some medications that you're going to make as compounds as well. So 3 uses when you're going to use combination medications frequently, when you're going to make compound medications, or when you want to set up all your common pediatric medications. Your drug sets / compounds list would be used for that. Here for the magic mouthwash, I can click here, select, and there it is, 100 cc's of Maalox, 30 cc's, 2% lidocaine, 1 tablespoon every 4 hours as needed. Do not, whatever, I could add it in there. If I want to, let's say I wanted to make that prescription, or another one. Let's say I wanted another magic mouthwash, but this one is going to be slightly different. I can go ahead and enter my ingredients here and add that in. So I'm going to say here, on editing this one, you see I've got the additional sig. I'm going to say take as needed, and I can put in the amount of grams or the number of cc's, and let's see, ml down here. There we go, and we'll say 100 just for fun, and save. And now we've edited that. Now if I want to make a new, or if I want to delete an item from the list, it's pretty simple to delete items from the list. Let's go see the muscle pain here. Click over here and I can delete that item from the list and it's gone. And now, if I want to make a new item, I can add an additional drug set. Click. And now that I have got that, then I can go ahead and let's close this down here. Let me do this again. Add additional drug set. And I have my choices here. It's not letting me do that right now. Oh, here we go. Yes, here we go. So now I put in the name, and I'm going to say this is for, pharyngitis. Pharyngitis. And I want to add the drug set. One click there. Now I have the pharyngitis here added, and I can select that one. And now, under pharyngitis, I can go ahead and pick this one here. Here it is. And we're going to select the drug. So under pharyngitis, maybe I want to give PenVK. Penicillin, maybe I type in just the letters PEN. There's a lot of meds here. Maybe I should have put in a few more letters, but you can see I can find it here, even with that. And here's my PenV, 500. One click, pick that. 1 tab by mouth, and I'm going to say BID, and I'm going to change it to 2 tabs. So I click over here, 2 tabs by mouth, BID for 10 days. That makes number 40. This is the one place I cannot add this to my doctor's list. If I'm adding it to a drug set or compound list, I cannot add it to the doctor's list because the drug set or compound list is shared by all the providers in the clinic. And we're going to say, just to put in a sig here with food. Although not necessarily recommended, we can do that there. Okay, so now this list has penicillin on it. And let's say I want to add another medication. I always do ibuprofen with penicillin here. Well, I can do that then. I can go ahead and select another drug, type in ibuprofen, and now search. And you can see lots of ibuprofens here. And maybe I want to do a 400 milligram tab, one tab by mouth, PO, QID, number 40, and we'll say with food, and save. Okay? Now we've got that information there, and we've got both the penicillin and the ibuprofen there saved, and I can close it out. And let's go back now to composing the prescriptions back here to the drug sets or compounds. If I wanted to do that pharyngitis list, I just click here, select, prescribe all, pen and ibuprofen have now been added to my list here. Okay, now let's take to complete review page. There's a problem here. I got a lot of meds that maybe I didn't want to do. I've got indomethacin and ibuprofen. I've prescribed 2 penicillin medications, amoxicillin and penicillin, both of which the patient's allergic to. So I get one last warning, are you sure you really want to do that, doc? And so maybe I didn't want to do it, maybe I did. You do have the freedom to prescribe a med the patient is officially allergic to, but you certainly want to be careful doing that because you probably want to document somewhere, if not in a progress note somewhere else, that, hey, there's a reason I did that. It made sense for this particular patient. So we're going to go ahead and leave this at indomethacin and penicillin for this patient. I still have some warnings here, but not a lot of warnings, and I'm going to go ahead and transmit it. Once I've sent the transmission, it will come up with the pharmacy that was selected by the front desk. I can always click and change it to a different pharmacy for that patient, and then I can click transmit. And once I click transmit, it's gone to the pharmacy, and I can say finish prescribing at that point. Now, I just want to go back in here to the prescription window and just talk about a couple things. Over here in the administrative page, if you're a medical director and you got a new provider coming in, you can say copy a list of my doctor's meds, my provider list, from me to somebody else. 2 clicks, and then go ahead and copy. And when you have to have that person set up in the system before you can do it. And I will warn you, do not think you can call on the day that you're going to, the provider's going to start working and think that e-prescribe can be set up for them in one day. It takes several days. I'd recommend you leave at least 3 or 4 days for that setup, because SureScripts, which is basically the program through which almost all e-prescribing occurs, SureScripts actually takes a few days to propagate the information throughout, and so you cannot be set up in just one day to do this. It will take several days to propagate and be completed. So always give us, I would recommend, a week before a provider starts, let us know. And then I would also recommend that the medical director always go in and give the new provider the doctor's list of medication, the one that you have, or if you want to make a standard one that's not the one you use, you can do that too. So they have a nice list of medications to start out with. There's also a lot of help here, a lot of information about how to use the system, how to do the location pharmacy list, how to there's all kinds of support here and little videos on how to orient you to e-prescribing. So there's a lot of help over here on the administrative tab, and I encourage you to use that. The other place there's help for you is over here, and remember we opened the practice management earlier. In the practice management system, under Help Resources, Help menu, Help Resources, top right-hand corner, same as in the e-prescribe, same location anyways. You can see there's a tremendous amount of information here. There's user guides, there's administrative documents, outside links, other videos. There's training videos, including the VelociDoc videos. This video that we're making right now, this training session, will end up over here in the VelociDoc section here, and it'll be VelociDoc 16 15.2 release, updating this 15.6 release that was here. Then there's all kinds of other videos here to allow you to learn how to use the PVM system or the VelociDoc system. And they're not so much talking videos as they are videos where you watch somebody actually do a process and then you do it yourself and it tells you if you're doing it right. So it's an opportunity for you to do your own training. Front desk folks should go through all of this PVM training over here, and clinical teams should go all the way through this VelociDoc training here. It's all available to you. It's very well done, and I encourage you to take advantage of that so that you're very comfortable using the system. I know it's easy to use, but there's a lot of functionality that you may not realize are there if you just use the system cursorily without getting full training. Now, what if the patient has a different complaint? What if the patient has abdominal pain? Or back pain, we'll say. I click on back, and, oh no, back pain is not a good example, excuse me. We're going to go back to abdominal pain. What if the patient has abdominal pain? And we put in here it's spasmodic, and it started yesterday at exactly, we'll say 7 p.m., and save that. And we'll say it's constant but worse at times, and the patient rates it as a 10 over 10. Now, in this case, there would be no chartlet. You notice there's no chartlet icon next to abdominal pain as there was over here next to the sore throat complaint. So back to the abdominal pain one. That means this chartlet tab, if that was the only complaint, wouldn't even show up. And I wouldn't have all this functionality related to just abdominal pain. I do have it for the sore throat, but the second complaint I don't have that functionality for. Over here in the exam tab, I now have the abdomen exam showing up, and I can actually document that the patient is tender right here. And if I want to, I can even write here tender. It's not a replacement, and certainly not a legible replacement for much of anything, but it's not a replacement for documenting here, over here on the chart here. So I'm going to say there is tenderness, and I'm going to say not to light palpation, but to deep palpation in the right lower quadrant. I recently audited charts, and it said that the patient had tenderness to light palpation, but no tenderness to deep palpation. I must say, be careful of documenting silly things. If you're tender to light palpation and it's significant, you're going to be tender to deep palpation as well. It's like doing a diastolic blood pressure when it's only when the blood pressure is only palpable. There's no such thing. Okay, we'll say no guarding, no rebound, or we could say yes, guarding, and we could say it's right lower quadrant, or we could say it's diffuse, right upper, lower, left upper, left lower. And we'll say rigidity is negative, and rebound tenderness we'll say is positive diffusely as well. So this is obviously looks like an appendicitis on this abdominal pain, and we can go ahead and save this. By the way, if I want to edit that, I can just click here on the words next to it and pull it up here. And let's say I want to edit something and make something a little differently. For example, I want to note that the diagram was utilized on this and save. And now I can note that. We've documented this, all these things, but what if I wanted to note here that the patient was in no respiratory distress, breath sounds or auscultation were negative, but I want to actually note a little more specifically about those breath sounds. I can click over here on to the right of that item and still bring up the information here and note that, remember I already said that it was negative, but now I want to say there's no tracheal breath sounds, and the volume of breath sounds were normal. There was no rales, no rhonchi, no wheezes, and save. And now even though the patient has a normal exam, and I've documented that by clicking on the green box, I have now noted over here that the patient has specific findings absent or specific findings present, but in which case it's completely normal. If we go up here, I could add gait and posture, and I could say there's no cervical or inguinal adenopathy, no ecchymosis or rash. So there's additional information I can put in here as well. Now if I go over to transcription, you can see I've added a lot more transcription here. Here's my physical exam. Here's my physical exam. All of these items are now negative. But up here you can see in the ENT and the GI, there were some abnormalities noted, and that's been documented there. So we've documented an additional complaint, and we've gone into the actual template itself, the physical exam template, to document that. We did not do that from the chartlet, and that'll be your choice. Most of the time, if there's a chartlet available, you'll want to use the chartlet, and you'll want to document on the chartlet. But if you don't want to use the chartlet, or it's not available for that complaint, you can go through each tab and document. Now, we've been through here and we've documented multiple things, but we haven't been into the labs tab per se, except as an MA or nurse to document results. So let's go in there and get locked to edit. Now, it's important when you get locked to edit, if it warns you somebody else has that part of the chart, or if you go to open a chart and it says that chart's been already opened by somebody else, do not go forward. The only situation you should go forward is if you know Mary Jones had that chart open. Yes, she had it open. Her computer crashed. The hard drive's gone. That's never going to be opened again on that computer. Or you know Mary's gone on vacation. There's just no way you're going to get that back. That Mary worked yesterday, and you know that she still doesn't have the chart open. Well, she opened it but never saved it. That's a problem. You can open it then. But in almost all cases, if you are warned about opening a chart, do not open that chart, because you will delete you'll delete almost all the work, if not all the work, that was done by that other person while they had it open. So instead, if somebody has a chart open, the whole chart open, and you need to go into the whole chart, which is very rare, but if they do, go ahead and talk to them about that and ask them to save it so that you do not lose that information. Now, we're here in the lab section. In the common orders, you can see here, I'm going to have common in-house testing to be done for a sore throat, common in-house testing for abdominal pain. I can also go here to the lab orders, and if I have a LabCorp integration setup, or a Quest integration setup, or another outside lab, I can do that. Here's my in-house lab, and what I can do in my in-house lab. These can all be customized for you, whatever you want in the list. The Quest list is not the entire Quest list of labs. That would be a list that you wouldn't even want to see. But you put the list you want for your clinic there. All providers will see the same list. And if you find that CMP is not on the list and you want it on there, you can do that. Some people have complained that LabCorp and Quest don't have the exact same wording for the exact same tests. Unfortunately, because we have to load their compendiums regularly, we cannot hard code names for different tests into the system, and we have to use the names for the tests that Quest and LabCorp use. So you have to get used to that a little bit. The Quest and LabCorp integrations with those two labs are available for free, but they do take a little bit of time to be done. But we've covered all of the expense for you to do all of the integrations for you. That's all covered for you. You don't have to actually pay anything for those integrations. The same thing is true right now for actually getting the setup of the integration with teleradiology specialists. There's no extra charge for that. Okay, so we've got the labs here. We can order them from here, and let's say I have a Quest order. I can order it from here, and when I order that test, it will allow me to not only order the test, but put in the information that's needed. So I'm going to say that in this case, the practice is going to bill. There's some billing information that unfortunately you're going to have to learn for each payer. It's not automated right now. We can go ahead and put in a note to lab technician if we want. Typically, you put in the venipuncture and say it did it by venipuncture that was successful. Right antecubital fossa, had one attempt on that. So you can put a little more information. If you want to bill for specimen handling in addition, you can add that as well. But that's typically only if you're delivering it to the lab. And we've got this here. We're going to go ahead and save it. Now you say, well, how about the results? Well, the results will come back, but right now they're not back yet, and it will tell you if you made any errors. So if I've made an error, I haven't entered the specimen type, it's going to ask me to put in the specimen type. If I've made an error and missed anything else that the lab requires, it's going to ask me to do that as well. There's also down here Ask on Entry, containers and specimens down here. So there's a lot of information here where I can put in the information on what they're looking for. So let's go back up to the top here. We've got the put that up there. Okay, and you can see there's a lot of data that the lab requires here, order number, who's entered it, date entered. Some of this is automated, the session number, the status, the priority, who pays for the lab. This is a Practice Velocity internal lab. This is the lab facility, and you can see, oh yeah, I picked Quest, you can be sure of that. The status, the date that I did it, the cost, charge, and insurance is not noted here at all. And we'll go down here, and here's my specimen ID, my type, and in this case I would say, go down here. You have choices of plasma, I have a choice of serum, and I can say that it's refrigerated or frozen, and then I can save this. And now that's saved. We do have plans in the future to automate some of the specimen types, but currently you do have to put in the specimen type yourself. I'm going to say it's collected, but I'm not going to click on reviewed, because I'm not going to click on reviewed until those lab results come back to us. I'm going to spend a little bit of time here on the procedures with the time we have left. Procedures that I might order. I click on the Procedures tab, and I've got a lot of sub-tabs here under this. So let's go through what we have here. First of all, there's common orders. These are common orders related to the complaints, to the sore throat. These are the 5 most common orders beyond X-rays and labs. And you see them right here. Here on abdominal pain, I'm not sure why Toradol is being given for abdominal pain, but I guess once in a while it might be appropriate, depending on the source of the abdominal pain. But these are able to be ordered with a single click. These are all in-house things, procedures that would be done. On a CPT search, I can search the search here. So if I type in laceration, I'm going to show you this to you, because you are not going to find any of the lacerations you're looking for here. You're going to find cornea, you're going to find all kinds of things, but the code description does not have the word laceration in it. If I do wound repair, oh, excuse me, I put an L there, wound repair. See if I can do a better job. There we go. And now here are all these wound repairs. This is not the way you want to document a wound repair. The reason is, when I click on that, I'm going to get a generic template to document on where I can type in all kinds of information about the procedure. That's not how you want to do a wound repair, though. If you're doing a wound repair, you come over here to the Skin tab, Skin Procedures, click on Skin Procedures, Wound Repair. I'm going to do a finger, so I'm going to click on neck, hand, foot, genitalia, toe, or finger. And now I'm going to say this wound is in the left index finger. And I could say distal phalanx if I wanted to. And I'm going to say that I did a simple repair. It was 1.2 centimeters long, which you're supposed to measure after you have repaired. Let's go down here. We'll say it's linear, clean. I could put in depth and width if I wanted. I can say I did some anesthetic. And if I injected it, I can say I did a digit block, and I did a 2% lidocaine, and I used 8 ml. And I can put expiration date, manufacturer lot number. I can put it in the NDC number. And I can put in the brand name and so on. Then I can go down here and say I irrigated it, I scrubbed it, I did a betadine prep. If I want to talk a little bit more about irrigation, I can document, say I used 500 ml of saline, and the wound was draped in a sterile fashion. I did no debridement. And down here, here's my repair itself. So I click on, I'm repairing not sub-Q and skin, but not tendon, sub-Q and skin, not muscle, tendon, sub-Q and skin, or any combination of those. I'm just doing the skin here, or the mucosa, and I'm going to say I repaired that with 4-0 nylon simple interrupted sutures. That's done. I can talk about a dressing here if I want to put it on here, Band-Aid maybe, or a Telfa pad. and then I'm going to say neurovascular is intact prior. Obviously, I'm not going to check it after I do digit block. Patient tolerated well after ambulating without difficulty, and save. I'm going to delete that first one because that was a mistake. And anytime you can find a specific template for a procedure, use that specific template. It's so much more helpful to do that. Now, if I want to document a procedure before I go in the room, let's say the nurse is setting up the patient for that lac repair. That's great, wonderful. She goes and does that. I know what I'm going to do, but right now I have no other patient to see. I could have gone in and documented this whole note, but there's a possibility I'm going to change it, and I don't want that chart to be confusing to me and let me think that I've already completed that note after I know what I did. So I don't know for sure what I'm going to do, and so I leave this done box unchecked. So now I'm going to go in here and click here and on the note itself. It'll pop back up, and let's say I said, you know what, I didn't use 4 for our nylon, I used 5. Oops, clear it, 5 for a nylon, and save that, and that's done. Now I've done the procedure, and I'm going to say done, and it'll turn green, and I won't get a warning about that when I go to discharge the patient. So we talked about the CPT search. Don't use it unless you're sure the procedure isn't here. Ortho is dislocations and joint injections for the most part. Also crutch training, finger toe taping, these sorts of things are here. Supplies. If you're using a supply in a procedure and you document in the procedure, or if it's available to document in the procedure, don't document it a second time. This is for supplies that were not used in a specific procedure, or you're billing for them separately. But in general, supplies for a procedure are included in the procedure itself. Pain management is a separate tab for folks who do pain management care. Fracture, if you actually have the patient for a fracture, there's 2 types of fractures as far as which template you're going to choose. Definitive treatment is where you're treating a fracture and you are doing the treatment that's going to be needed to that you're deeming at this point at least it's likely to be curative. So for a finger sprain, for a finger fracture, it may just be a finger splint. For a wrist fracture, however, it may be that you decide to do casting, or you decide this is a buckle fracture that only needs a wrist brace of some sort. Then you are doing definitive treatment. In general, you're not sending the patient to an orthopedist. However, if you're stabilizing and sending the patient to an orthopedist, then you would pick the stabilize only, and you would document on that. Now, in addition, rechecks. Rechecks here, if you're doing a recheck for a patient for an IND or a LAC recheck, you use this template right here. Medications, this is in-house medications. One thing that is not in the system yet, we expect to add later this year, but it's not in the system yet. There are no allergy checks or no drug-drug interaction checks on the medications that you give in-house or on the injections you give in-house. We do expect to add those later this year, but they're not there right now. So just a word to the wise, you need to watch for those and don't expect the system to warn you in the system right now. There's a whole bunch of wellness templates here for quality preventive care, and there's a functional safety assessment, risk for depression, psych assessment, and so on there. Tests over here, this is where you'll find your EKG, you'll find your visual acuity, audiometry, and so on here. Skin procedures we already looked at include wound repairs, foreign body repairs, removals, and incision and drainage. We don't really recommend use these visit codes. This should be done elsewhere and are, for the most part, automated, so it doesn't make sense to use them too much. Injections here. These injections, again, we do not check for drug-drug interactions or drug allergy interactions, but you have an opportunity to do all kinds of injections from this template. And there are other labs that are not ordered from the lab tab that make sense in some in-house settings. For the most part, it doesn't make sense, but drug screens are here, PPDs are here, and the Piccolo general chemistry, and there's a shortness of breath template that goes along with that. So you can use those if they make sense for you, but for the most part, most of you would want to ignore those. Okay, so we've gone over all the procedures tabs here. Let me just show you one procedure here under medications. If I want to do a nebulizer treatment here, I click on the nebulizer treatment, and now I'll have an opportunity to put in quite a bit of information. I can say this is therapeutic or diagnostic. In fact, I must document at least that information there, and then I need to document at least one session. And it says here, you must document at least one session. Anything in bold is critical for you to document. Let's go in here, and we'll say session 1. We'll say we use an albuterol unit dose, 1 unit dose. We can put in the med information here on expiration date, manufacturer, lot name, brand name here, and then we can go ahead and do a respiratory exam after that first session, saying the respiratory evaluation is normal, no respiratory distress, and we can say here that right breath sounds are normal, left breath sounds are normal, no rales, no rhonchi, and no wheezes. And we've got that post evaluation exam done, and all that information showed in there as well. So you might have a physical exam that's a little different when the patient first came in. You can document the post-procedure exam there. You can also do post-treatment vital signs if you wish. Typically, if you're only doing one treatment, then your pre-treatment vital signs would be the ones documented in the chart. You wouldn't necessarily redo them in this template. At the end of most procedures, you can say patient tolerated well, left room ambulating without difficulty if you want. And then we'll say here it's done. I might not, until it's done though, don't click done. And then there'll be a reminder to you if you're trying to discharge the patient and you have not completed it. Now, a couple things just additionally about the chart. First of all, over on the right, we talked about transcription, which I can see my transcription on my chart at any time I want. Then I can go over here to demographics. And most of the time, there'll be an ID card here for the patient, or if the patient's a minor, for the parent whose ID card was used. All the demographics show up here. Visit history, I can see previous visits. In this case, there are no previous visits, but I can see diagnoses, CPT descriptions, provider to provider notes. This is where you see that, addendums, plan. But I can also see here, and I can filter just to see private visits, just to see work comp, and so on. And I can ask to see even more information. Now I can actually see the actual codes that were coded here, and I can see over here. Actually, that's the only thing additional that I'm seeing here when I do that on this particular one, some extra codes. Let's hide that. We did visit history. Let's do previous vitals. This will allow me to actually make a graph of vitals. Now, it's not going to be fairly nonsensical since there's only one systolic and one diastolic reading on this patient. But over time, if I have weight or height, or I can do that. And for just to note here, under the height, I am able to zoom to ages 0 to 2, and if the patient has data in here, it'll actually show me the normal growth curves for those patients. Of course, there's no data there, so it doesn't make sense to show the growth trends here. Yeah, we've got this here. Let's hide that out. Okay. And lastly, let's pull this up here. Revisions. If I want to see the chart anytime it's saved, now this chart has only been saved once, but it was saved multiple times, I would be able to see all of those changes before. But if you remember, I saved it once right at the beginning of this training. And when I saved that, there was only the history in here. There's no physical exam here. I can see that when D. Stern, that's me, but let's say it was the MA, saved it, there was no physical exam. There were no procedures. There were no labs. All that was there was the history. I can see that. And then I can see, after I save the chart this time, I'll be able to see what's there at that point as well. Go ahead and hide that. Okay, I'm going to go ahead and say this nebulizer treatment is completed. The labs tab is still red. That's because I have a lab that I'm expecting back. I sent a lab out and I'm expecting that result back, so I'm going to leave it red. But most of the time when you have a red tab, you're going to say, oh, why is that red? Well, this is a CBC. It was sent to Quest, as you remember. So, and I can see that right there. So, oh, I expect it to be red. No problem. It's time to go ahead and discharge this patient. And I can do so. One thing I forgot to mention, here in under the clinic button here at the top, I can pick the A&P tab note maintenance. When I do that, all of those notes that showed up where I can pick those notes from the drop-down show up here, and I can add more. So first of all, I'm going to delete C Dawn in 3 days. Click, and it's gone. Now I'm going to add one and say C Joe in 3 days. I don't know why I would ever write that, but there's lots of notes here, and I save that in. Now when I go ahead, and I'm going to close this out, when I go in here to the assessment and plan, and I go to the disposition, I click here under the additional discharge notes and go to the bottom. Here it says see Joe in 3 days, and I can click on that and add that. I can edit it, or I can actually say, so let's say I didn't want it to be Joe, but I want it to be Mary. I could do that here, or I could save myself a new note. In addition to having the ability to add notes and delete notes, I can change the order that they're showing up here. So the AMP tab note maintenance, I can go in here and I can say, you know what, that see Joe in 3 days, I want that to go to the top. So I just click here really fast, multiple clicks, and see Joe in 3 days is now all the way at the top, I think. Let's see. Yep, there it is, all the way at the top. Discharge notes are available to you. Also, provider-to-provider notes. We talked about the importance of doing that in workers' comp when you're communicating to the next provider. And those are available. You can free text them anytime you want, but you can also add provider-to-provider notes to your drop-down. These are the 2 drop-down lists that are customizable for you. A lot of folks put in some information about providers they're referring to, so they have notes about addresses and phone numbers for providers. You can do that here as well. We will be adding more functionality to allow some really slick referral functionality in the system, but that's going to be added later this year, so that's not in there right now. Exit care, you can look at the document that's going to be printed and given to the patient here, and there you can see what it was. I can say if I want them in Spanish, they are available in English and Spanish, and you get both languages with the system. Now to discharge the patient, I go to discharge the patient. It says there are unset labs on the chart, discharge anyways, and normally I would say no, I need to send them at least, but in this case I'm going to. And now I'm going to allow this chart because it's an unsent lab, and because there's a lab that's not complete, I should say, I would allow this to be incomplete, discharge now and sign later. And I'm going to put in my password here. And now accept my digital signature. This particular patient will get the patient clinical summary, the work note, the school note, and the exit care all printed out at the same time. And so you print that out and hand those to the patient. This patient has not got a completed chart. I'm going to complete later. And I'm going to say it's in the labs pending results and the labs pending completion, and save close chart. And now I have them in those queues, but they're done. Now the queues that they'll show up in for work queues for labs do show up over here. If I click in the top left-hand corner, I can see here's that labs pending results queue right here, and you can see Speedy Chartlet is now in that particular queue. Speedy Chartlet is also done here, but I did not sign the chart, so it's going to be in red. Now in some cases that's the correct thing to happen, because I'm going to sign that chart later when I finish it off. But in other cases, most cases you want to make sure you go back and sign the chart. It says here that it's not signed, and I know that now by looking at this. We can also the other thing I wanted to show you is here about giving instructions before we're done. Last thing here you do is go to the patient, and you can have a tablet set up where the patient can actually go ahead and sign on the screen if you hand them a tablet, and then they would hand it back to the staff. The staff would then go here and save that out. So once that's happened here, it should change to signed here in the instructions. For some reason it's not doing that here. It looks like that's a little bug on my computer rather than a problem. But it would say signed when they were done there. Let me see if we can do it one more time here. There, save, There we go. It did it. So now it shows that it's signed, and if you decide not to have the patient sign the charts, but you want to just give it and note that you gave it, you can also do that here. You can set up your practice to default to just giving the instructions and noting that, or you can set it up to have the patient sign for it. You'll need a tablet of some sort or some sort of a touch screen that you hand to the patient for them to sign for their instructions if need be. We're going to take a short break here. We'll be back in 3 minutes to pick up the second webinar. Second webinar will be specifically going over Chartlet.